we have phage therapy centers in the Midwest and on both coasts. So I think in the US, compassionate use phage is available and should be.
For this section of our interview on bacteriophage therapy, we'll continue our conversation with Dr. Sabrina Green, Dr. Saima Aslam, and Dr. Austen Terwilliger. You can find more detail about their backgrounds and their work in the description below. So this section of the interview is all about safety and side effects and the success rate of phage therapy. So the first question is whether there are any known side effects of phage therapy.
So phages have been in use for many years. In the Western medicine, it's just recent, but there certainly has been a lot of experience in Eastern Europe using phage for many, actually, decades. And so in general, it seems to be safe. However, especially as we do clinical trials and treat more patients with intravenous phage or other sort of very localized applications of phage, there have been a few cases in which we saw elevated liver function tests. And it's difficult to say if that was from the phage versus the underlying illness of the patient. So, a lot of these cases are compassionate use cases in which patients are very sick. And at times, there's multiple things going on other than just the treatment that we're giving them. So I think that's one. The other thing that I've noted in a few patients with very specific kind of infections, so drug-resistant Pseudomonas cardiac device infections. And again, we had an earlier conversation, when we selectively target one specific phage, it may allow one specific bacteria, it may allow other organisms to grow. So I've had a couple of patients that had cardiac device infections, that had bloodstream infections. The organism still remains susceptible to phage, and the infection resolved. But I think that's something to watch out for, and it probably is very pertinent just to cardiac device infections because they involve the heart. But in general, when we talk about phage, most of the time, almost 99% of the time, it's not going to go into our human cells, and so we're not really that worried about toxicity. The other issue, may not be the phage, but the preparation that it comes in. And I'll let Austen and Sabrina add in, but, it's usually very purified. So maybe Austen or Sabrina, you want to tell us the preparation piece and how we purify it so we don't have reactions in patients.
Right. Yeah. When it comes to phage, again, they are on and inside our body as part of our microbiome. So our body is used to dealing with billions and trillions of phage on a daily basis. As Saima was getting into here, the concern with high titer purified phage preps is something that might have co-purified with the phage. If it co-purified with the phage, it came from the host in which that phage was growing. So we must take great care to ensure that those components of the host don't end up in the preps. These are things like virulence factors and toxins, endotoxins, and any antibiotic resistance factors as well. And I'll pass it over to Sabrina to fill in anything further I missed there.
No, that's good. Yeah, we purify our phages. We use, I don't know if everyone wants to know, but we use ultracentrifugation and cesium chloride purification. These are classic ways of purifying viruses. And so we've really mastered that in the lab. And we do several tests to ensure that, our preps are very low in LPS and endotoxin, and have no toxin, exotoxins present in our preps before, of course, treatment.
And in this context, when you say host, do you mean bacteria?
Yes. So
okay.
we have to grow the phage in the bacteria. And so because of that, the preps could have contaminants of the bacteria. And so that's why it goes through a very extensive several-day process so that it's completely pure of any of those contaminants.
Okay. Could introducing new phage into the human body have a negative impact on the healthy microbiome?
So I think most of the times, so I also mentioned this, the healthy microbiome actually does have phages along with bacteria. Generally, when we're introducing phages on purpose, it's because the patient is not healthy and there is something we're trying to fix or treat. But again, yes, at times there can be unintended consequences. And so we think, and the goal is that if we're using such targeted phage that we're only really affecting the pathogen of interest, which hopefully will allow healthy organisms or healthy microbiome to sort of repopulate itself. But again, I think we need to do this enough number of times to know how that pans out. And yes, it may be that a different organism takes over, and that's not what we wanted, for example. But I think it sort of depends on the organism we're treating, the phage that we're using, and the actual sort of infection that we're targeting, which would lead to a specific kind of microbiome. So very generalized answer. Go ahead.
I would also like to add that this risk is the same risk posed by modern drugs as well, that are not as specific and targeted as phage. If you're using an agent that can get your microbiome balance out of whack, that can lead to the difficult states for the patient, and certainly some of the listeners would probably know C. diff quite well, which can be induced and caused by this dysbiotic state from the antibiotic use.
There are quite a few people in our community who have experienced C. diff, which raises another question of whether phage therapy could be used to target that.
There's a lot of ongoing research in that. I'm not aware of a clinical case where that's been used, but I think Dr. Martha Clokey's lab in UK is working on that.
Okay, I'll have to check that out then.
Yeah, definitely Martha Clokey would be the person to talk to here. I would say, in general, it is extremely difficult to find lytic phage against C. diff. So again, what we mean by that, finding phage whose life cycle is solely just infecting the cell, making copies, and bursting the cell. Really, what you find with C. diff are temperate phages, those phages that can infect the cell, but then incorporate their genome into the host genome and sort of just sit inside that cell and wait until they find a more favorable time to make copies of themselves and then pop back out and lyse the cell. The wisdom right now in the phage therapy field is that you want to stay away from those temperate kinds of phages, because you do have an increased risk of those phages picking up pieces of DNA from the host and transferring it to other places. So again, here you would be concerned about those temperate phages picking up toxins, virulence factors, and antibiotic resistant features. So it's for those reasons that it has been difficult to develop phage therapies for C. diff thus far.
Yeah, that makes sense. Can phage therapy cause die-off symptoms as it kills the bacteria it is targeting?
So that's something we traditionally think of in the setting of antibiotics. So when somebody has, a high bacterial burden from whatever infection, and you give, and you cause lysis of cells, bacterial cells sort of very quickly, yes, patients can actually have an inflammatory response. And we've seen that actually in some cases of phage therapy as well. So a rise in inflammatory markers such as C-reactive protein or ESR, which is the SED rate. And at times, within that first day or two, just having chills or fever or, kind of body aches. So that would go with, a response in which many, high bacterial burden infection is quickly lysed, whether it's with phage or antibiotics. So I think it's possible, and we have certainly seen that in a few cases as well. Usually patients do recover and improve, and then over time get better, and you see those inflammatory markers go down.
Do you think there's anything that can be done to speed that up or mitigate that?
So generally, when we talk about tamping down inflammation, the drugs that we use for that would be things like steroids or NSAIDs like ibuprofen. I think because this is so temporary and so brief, I don't think personally it's worth sort of pre-treating with steroids, for example, or, ibuprofen or other NSAIDs, because one, it's not that common. And second, we don't want to have that steroid effect then linger on and make it actually difficult for the host to clear, for the person to clear the infection too. So I think it's rare. We can use Tylenol or things to sort of help with some of the symptoms, but generally it's brief. So I don't think, we need to do anything specific for it other than kind of watch out for it.
Okay. And a couple of questions on safety and who phage therapy is suitable for. Can it be used during pregnancy?
I think it can, but I'm not sure I know for a compassionate use case, I can't imagine the FDA would allow us to do that without having safety data sort of extensively in the animal setting, unless of course it was sort of a Hail Mary effort in someone that's not going to make it. So I know when we do studies and when we develop clinical trials, we always don't want to include pregnant women. Unless, again, it's something that's very specific for them. So I think as of now, the answer would be no, unless and until we have sort of, detailed safety data in the animal setting prior to sort of trying that in people.
Okay. Now, are there upper or lower age limits to who can use phage therapy?
So I don't know. There are no age limits per se. We've used phage in babies, and we've certainly used phages in elderly patients as well. So there's no specific age limit, no.
Okay. And you mentioned using it alongside antibiotics, but what about other non-antibiotic things like UTI vaccines or Hiprex, for instance?
Yeah, so I think it should be fine. So again, phages and say, the vaccine or Hiprex, they're all acting sort of from different mechanisms towards that one goal of eradicating urine infection. So yes, I think they can be used alongside. Using one does not kind of cancel the other out. So especially for recurrent UTIs in women, a number of them are on Hiprex or other agents to help reduce that frequency of urinary tract infection. But the phage can be added on to that, yes.
Okay. And are you able to share any data on the success rates of phage therapy?
So I can only share data that I'm intimately aware of, which is patients that I've treated. And so I recently kind of put together a slide. So we, among sort of 15 patients that have, received phage and completed it, and we've had adequate follow-up, we had a success of 13 out of those 15.
Wow.
So that's about 77%, which is pretty cool, given that these were people that had already failed multiple rounds of antibiotics. Actually, sorry, 12 out of 15, not 13. But, multiple rounds of antibiotics or were very ill when we treated them. So I think patient selection is very important. There certainly are failures. There was one patient we treated twice because the first time around it didn't work, but then we kind of went back at it with a different phage and it did work. So there also, unfortunately, I'm aware of we have a few at our center, certainly at others as well, where phage did not work. And a lot of, I think, the negative reports or the cases where it didn't work aren't published. And I think patients tend to think that, receiving phage will cure all. So I think, maybe this is more personality, but when I talk to patients, I always tell them success is not guaranteed, right? At the moment, this is still experimental therapy, which is why we have FDA oversight every time we treat a patient. But I think in very carefully selected patients, meaning we are quite certain that the symptoms that they have are due to an infection, and we're certain that it's, one particular infection causing whatever symptoms, there's a pretty decent chance that we can, improve that or cure it. But a number of times patients reach out with sort of a variety of symptoms, and they may have a positive culture from a urine or, from a skin sample, or a respiratory sample.
Mm-hmm.
But that bacterial, it's usually colonization. It may not be the infection causing the symptoms. And I think in those cases, at times phages are used, but it doesn't help the patient.
Mm-hmm.
So I think careful patient selection is important. Obviously, the kind of phage we use is important to sort of improve, and have good, successful outcomes.
Have any large-scale trials been done for phage therapy? And is it even possible given the individualized nature of it?
So there are a few trials that have been completed and published, and certainly several more that are ongoing or hoping to start soon. Among what's been published, there was a paper in 2019 in which phage therapy was used topically. So a combination of Pseudomonas phages were applied topically to patients that had infected burn wounds. And so, this was in France and Belgium. So patients had burns, which were then infected with Pseudomonas. And they had one group that got phage sort of topically applied to that wound versus standard of care. And in that case, phage therapy did not work. So it was not better than standard of care. And part of the issue in that trial, and I think we've all learned from that, is that in that study, the investigators did not actually, take the patient's Pseudomonas isolates and test for susceptibility. And when they went back after the trial finished and sort of did that, they found that a number of Pseudomonas isolates actually were not susceptible to the phage that they had used.
Mm-hmm.
So, I think, one, it was a negative trial, but then we learned why it was negative, and that's something that can be fixed moving forward. There's another recent trial that was published, I think last year, also from Europe, in which a combination of phages that were active against Enterococcus, E. coli, Klebsiella were used to treat patients in a trial setting that were at risk of urine infection. So they enrolled patients that had undergone prostate surgery. And after surgery, patients have catheters in place to irrigate the bladder in that area because of bleeding and there's concern for clot formation. And usually those patients are high risk of infection. And so in this study, they enrolled such patients, and one group had phage that was instilled into the bladder, during this catheterization. One group got systemic antibiotics, and one group just had this sort of normal saline, what's called a flush. Mm-hmm. And in that situation as well, unfortunately, the phage, were not effective. And the thought was that we're giving phages into the bladder, but then we're also irrigating the bladder. So we don't know how much is actually there. Mm-hmm. So I feel like, these were things that make sense. But anyway, that's how the trial was done. And, that trial did not really show an effective response. So I think these trials have been done. What we've learned from them, and I think which will improve as we move forward for current trials, is you're right. We do that personalized approach. So a number of trials, such as for cystic fibrosis and urinary tract infection, will enroll patients only if their baseline E. coli or Pseudomonas isolate is susceptible to the phage that we want to use. Mm-hmm. And we want to give it in a manner in which we're, certain or have a high degree of certainty that the phage is actually reaching the bacteria that we're trying to kill. So those are undergoing. And there's another one looking at actually prosthetic joint infection in which, phage will be placed into that joint cavity. So that's ongoing. So hopefully, these work out better.
I hope so too. We had shared one paper of yours about phage therapy for recurrent UTI, and a few people asked us if they can get some follow-up on that, whether the patient is still doing well and whether you know that information.
Yes. So I personally have not seen the patient in a while, but at least 6 months before, yes, and that patient was doing well. There hadn't really been an issue with recurrent symptomatic urine infection in that patient.
Oh, that's great news. You also raised the trials that you are doing. So that kind of brings us to the topic of availability. Are you aware of any countries at the moment where patients can access phage therapy that is not part of a clinical trial?
Yes, I think that probably is more easily available than being part of a clinical trial at this time. So there are many centers in the United States and England, not England, but Europe, Australia, and Asia that do have phage therapy centers. So at UCSD, at IPATH in San Diego, we actually have patients that come to us from other parts of the country as well to get phage locally at San Diego. And then, there's Taylor at Baylor, Mayo Clinic, and a number of other centers have phage therapy that's available on a compassionate use basis. Europe has many centers. There's one in Israel as well. And then Australia has actually a couple of groups also. So I think we could make a list even and have this part of the website. Because
that would be really helpful.
Other people, because there are many.
I do want to elaborate because I am actually moving from my position to a position in Belgium. So I do know a little bit about what's happening there. So in Belgium, actually, it's a unique situation where you can have access to phage, prescribed phage by a clinician, and you can have a personalized phage cocktail for your infection. So it's a really unique system just just in Belgium, but I'm hoping it could spread across the world because it really combines what we're doing, personalized patient care, and then they can have it available without having to go through this FDA approval for each individual case.
Yeah, that is really good to know. And if we can get a list of the centers, I'm sure a lot of people will be keen to see that. We've also heard from some people that they've ordered phages in the mail. Can you talk about why that may or may not be safe or effective?
So we've had patients like that then come to us, for a second opinion. So one, I think, ordering things by mail, I'm not sure if the patients have sent their bacterial isolates. A number of times it's really just a culture report that they send to a center, and the center, will pick something based on that culture report and send it out. So it's not really tested against the patient's bacterial isolate. There's usually no physician involved to see if what we're treating is actually the cause of the patient's symptoms. And so they may not get better, and maybe they have a non-infectious etiology, to their issue. So I would not recommend that. I think it's important, if we do have somebody with recurrent urine infections or other infections in which they're interested in assessing for phage therapy, to actually be seen by a specialist, whether it's an infectious disease physician or a urologist, whatever kind of infection it is. And then to have, their physician really reach out to these various phage therapy centers to sort of develop that personalized process in which the patient's bacterial isolates, are matched against the phage cocktail, and we're confident that the infection is causing the patient's symptoms, and then treat.
Okay. And what about for patients in the US? Are they able to access phage therapy with your team at the moment?
Yes, for sure. And this is true, actually, for many teams in the US. I think, so at our center, we have patients at IPATH, we have patients that reach out to us and or their physicians via email usually, and we'll help, depending on where that patient lives, help find them a phage therapy center that's close to them, so that, it's not, it's not a stretch to really try and get there. But certainly we've had some patients that actually flew into San Diego or drove in from other places in California to get phage as well. So again, we have phage therapy centers in the Midwest and on both coasts. So I think in the US, compassionate use phage is available and should be. And at many centers, we work with other centers where they may not have a specific phage therapy center, but they have one patient that they think may benefit. So, we at IPATH and, also Austen and Sabrina at Taylor will work with that center to help develop a personalized approach. At IPATH, we actually share our protocols. I usually work with the treating physician to help develop a treatment plan. We'll give them, sort of our protocols so they can copy, paste, and change based on their individual situation to help with that process. So people don't have to be at a phage therapy center specifically to get phage.
That's really interesting. And you mentioned earlier that C. diff, for instance, there is no inappropriate phage at this stage. Are there other organisms that might cause UTI that people could end up in that same situation, or can you usually find something appropriate?
So generally, urinary tract infections are caused by E. coli, Klebsiella, Enterococcus, and Pseudomonas. That's sort of, maybe probably 95% of urinary tract infections. And there are, especially for E. coli, Pseudomonas, and Klebsiella, well-developed phage libraries, both at Taylor as well as many other centers worldwide. So I think they should be treatable. Enterococcus is an organism that people are developing phage libraries. So at UCSD, one of my colleagues, Dr. Pride, is developing an Enterococcus phage library so that it will be easier to treat. But also, again, there are many centers, that can either look for a phage or have some existing phages against Enterococcus. So most urine infections should be treatable with phage, assuming they've already failed antibiotics or, we're trying to prevent recurrences.
Yeah, a lot of the people in our community have antimicrobial resistance or they failed antibiotic treatment. So this is of interest to them. But what are the criteria to be suitable for compassionate use?
So compassionate use in the US is dependent on, as you mentioned, so one, it's a drug-resistant infection, perhaps for which we have no suitable antibiotic, or we have an antibiotic that the patient is allergic to or has already had toxicity from, or, we've treated them and we have a bug that's susceptible, for example, methicillin susceptible staph aureus, joint infection. We've treated them with antibiotics, but we still keep on having clinical failures. So all or a combination of these are all reasons to try compassionate use phage therapy. And the FDA, in sort of these well-defined cases will generally help us. They've been actually great partners and have tried to help, all of these patients by approving phage therapy, making sure that it's safe to use for the patient. We don't want them to get worse. We want them to get better. So yeah, I think just having MDR or having failed antibiotics, those are sort of two, easy reasons to be able to get compassionate use phage.
Yeah, that's really interesting. It doesn't sound as difficult to access as it might have. And one last question on availability. How much does it cost for someone to get phage therapy? Can you provide any insights into that?
Yeah, so currently in the United States, and I can only really speak for the US, I'm not sure how other countries, sort of work out costs. So in the US, it's considered experimental. So generally a company, there are a number of pharmaceutical companies that are developing phage cocktails as well. They don't charge the patient, and we don't charge the patient for compassionate use cases. And many of the phage groups that we work with do not charge the patient either. But the treatment, so having an IV in place or getting the antibiotics and, safety labs, all that stuff has to be paid for. Generally, the patient's insurance will pay for, blood work and intravenous labs and things, intravenous catheter, but that really depends on each patient's insurance. But again, as a center, we don't charge for giving them phage. At times, because it's becoming so popular and certainly takes a lot of time and effort to develop a phage cocktail, there is interest in, in some centers will use, at cost. So whatever it costs them to make the phage, they will pass that on either to the center or to the patient. But we've never not treated somebody because they couldn't pay for that. I think, if a patient really needs it and they're unable to pay for it, usually, the center or other groups will kind of come in to make that work.
So it is available for patients, but it's, centers like our center at Taylor, we're still, if 100 patients came to us wanting phages, it would be difficult for us to produce that much phage in order to treat all those patients. So, people need to be aware that, even though there are a lot of centers around the US, we still have limited capabilities to treat everyone. Of course, if there's more demand out there, hopefully more centers will pop up and more groups around the world will be helping out to develop these phages. But currently it may take a while, if you are able to get compassionate use care, to actually get the phage because of the limited availability of these centers, to have the time and effort to put into making these phages.
Sorry, yeah, we certainly have more asks than hands at the moment that can help with these cases. I just wanted to recap a few points along this pipeline. Again, when it comes to types of infections and patients, we are looking at recurrent or stably chronic patients that have been in and out of cycles of the hospital and treatment with antibiotics. And as we had mentioned previously, I wasn't sure if it's in this section or the one past, that we really want clonal strains to work with, that patient's infection isn't changing much over time. And I also think it'd be good to point out how the process generally works with Taylor and IPATH. So basically speaking, Taylor is the manufacturer of phage cocktails. So if patients are interested in obtaining phage therapy, they need to consult with their doctor, hopefully an ID doctor first, who would then reach out to us or go through IPATH to work with us in order to manufacture that cocktail. And then once we have gone through our long checklist of items that are needed to ensure that phage cocktail is ready to be used for treatment, then we hand that cocktail over to the doctor and hospital to treat the patient. So I hope for at least people listening in the States, or at least thinking of coming to the States for treatment, that they have a better idea of how that works with us.
The other thing I'd like to add on to that is it can take weeks to months to actually identifying a patient, getting their bacterial isolate, finding phage, manufacturing it, getting approval from the FDA, and then actually getting it to the patient. So sometimes people that reach out are critically ill in an intensive care unit setting, just very close to passing away. And in those cases, there's really no time to actually get them phage, unfortunately. And hopefully, as phage becomes more widely available and we have products, at some point that are off the shelf that can be used for those cases. But currently, yes, ideally, because we know it's going to take months, it would be patients that have either recurrent infections or say, a joint or a cardiac device infection, which they may be on antibiotics, intravenously for months, but they're sort of, stable enough to actually be able to wait until the phage is there to treat them along with their antibiotics. So it's not instant, and generally will take many months.